Good morning, Chris.
Here we go. Hey, good morning.
Hey, Chris,
Good
thank
morning,
you.
Jihad.
Thank you for joining us, my friend. We have Dr. Daz, Dr. Noor, Dr. Garcia, and Kovac here with us on the panel, and an audience that is waiting for you.
Fantastic. Well, first of all, Jihad, welcome to Kingsport, Tennessee. We are thrilled to be part of the AMP meeting and appreciate the invitation. The meeting is fantastic and keeps growing every year, and again, we're honored to be a part of it. Before we start, I'd like to introduce our team briefly. To my right, good friend and newest partner, Mark Aziz. Mark did the Viva Fellowship with Jim Joy, lots of experience, and joined us a couple months ago. So Mark, glad to have you here.
Glad to be here, thank you.
Rahul Sakuja, our other partner, is on vacation, but sends his love. To the right, dressed appropriately in Chicago attire right here, is Ben Harrison. And he loves the bear, so he was the right guy to scrub. And then behind us, we've got our nursing expertise with Mike Hubbard and Sarah Allen, and back there on the keyboards is Jimmy Browder. So again, welcome, and we're glad to be a part of it. Let's go to our slides, please. Okay, next slide. A couple things I'd like to say first. Thanks very much to Boston Scientific for their sponsoring this, but I also want to give a shout out to them and an acknowledgement. We had a lot of changes here in terms of live cases this week. As that happens with CLI, some people had to be done earlier, and I was in contact with them. We were going to do a peripheral rotablator case and said that we may not have a case that's perfect for that, and I want to tell you that they could not have been more clear that they have an expert panel, they support the AMP meeting, and what they are here for is education, not promotion. And I mean that they said that sincerely, and so I want to applaud their integrity as well as their support there, so thank you, Boston Scientific. Lastly, before we start, I want to give you a neuromuscular disclaimer. What I mean by that is I've got a C7 nerve root that is really crazy. I'm going to get injected on Tuesday. So if you see twitching or grimacing, I haven't developed anything. Our staff was going to twitch with me, so you thought it was a Kingsport dance thing, but I just figured I'd just tell you that out loud, and I may pass things off to Mark Aziz if we need to. Now, if I say something inappropriate, that could be neuromuscular Tourette's, and I'll blame it on that, but otherwise, this twitching is a C7 nerve root. Next slide, please. All right, so our case. This is a very nice gentleman with lots of disease, as you can see, including endarterectomy and bypass, long-standing diabetes, and the other risk factors that you see. He's had claudication bilaterally, but then had a relatively sudden onset of an ulcer on the right great toe, possibly after some local trauma involving the toe. He's been seen in the wound care clinic with fairly slow but definite some healing. And then saw Mark in the clinic with ABIs and a duplex, as you see there, fairly low numbers with exercise, and high velocities on the duplex in the distal right SFA, as we'll show you in a moment, and a probable popliteal aneurysm. His posterior tibial artery is out, and he had high velocities in the anterior tibial artery. Okay, next slide, please. So this was Mark's angiograms. And it's a little bit of a surprise compared to today. You can see a little bullet fragment, stenosis, and then aneurysmal disease. And you can see the anterior tibial. Well, I'm going to let that loop again, and we'll let it loop. Notice that the posterior tibial is out. And then let's watch that run through again. There was a lot of calcification with this disease after the bullet. Aneurysm, and look at the anterior tibial, very high osteo disease, PT's out, but reconstitutes. And again, remembering that the ulcer is in the right great toe and second toe, and mainly the great toe, okay? Next slide, please. So let's show today's case, which shows a little bit of difference, maybe perhaps in what we were thinking ahead of time, and that's how we, you have to roll with the live cases, and we'll appreciate the expertise and the panel. So what I'd like to do is show you the angiograms that we've done and a representative IVUS image, and then stop and get an idea from the panel on what you think, and there are obviously a lot of ways that we could do this, and we've discussed probably every one of them in triplicate. So let's go to our live images, please. So you can see that he's got large vessels, but no true aneurysms up there. Similarly in his iliacs. We use that as a smart map to go around. And here's your runoff. Now today, as we go live, these vessels look larger than what we thought before. And the AT, I'm going to stop there, which had a 90-degree angle and looked pretty calcified on the previous angles, still has that 90-degree angle. And some of the disease downstream does not look as prominent. And then you see he's got a huge perineal, and there's the reconstitution of the posterior tibial. And somewhat surprisingly, not seen on the initial angiograms, where that perineal really reconstitutes pretty well the dorsalis pedal artery. Okay, does everybody see that?
Mm-hmm. Yes, we do.
So we'll take, all right, so now we're going to take a couple additional angiograms. And you can see the AT is pretty tight there at the ostium. We IVUS, and we'll show you that in a moment, the PT, and you can see the posterior tibial nub there. And you can see that the dorsalis pedal artery does come in. See it right there? I'm sorry. I'll let that play a moment. So the anterior tibial is still intact. It just feels slower than the collaterals from the anterior tibial. Okay, Mike, help him see if he needs anything. Okay. All right. So everybody see that?
So Chris, your suspicion that the anterior tibial is filling late because of the osteal lesion in the AT?
So it's a good question, Jihad. And so the question is, with this aneurysmal disease in the popliteal on the relatively sudden onset, is it a combination of the osteal lesion plus minus an embolic event, and then strong collaterals which have developed maybe because of the anterior tibial artery, and maybe a combination of all of those above? So we've IVUSed here before we came on, and we're actually a little surprised by some of our measurements. Can we show the anterior tibial? Let's see if we can go to our IVUS images. Can you see those, Jihad?
Yes.
Okay, so go ahead and play that. This is in the anterior tibial, back into the popliteal. We can see it's about a 3-0 vessel, but the popliteal artery is larger than what we would have estimated. We thought we would probably need a 7-0 Viabon. I think we may have to upsize that. So go to the next images that we had saved, please. So these are some measurements in the popliteal artery, in the reference segment. And I think that everybody would agree that we probably can't use a 7 Viabon given those measurements if we're going to use a covered stent there. All right, next, we'll show the aneurysm just briefly. Okay, and you can see we don't have to measure that, but it got very large and very big, and some gradu in there. And then I'll just tell you for sake of time that we IVUSed the posterior tibial that was non-obstructive, for sure had plaque, but not bad, okay? And then the disease proximal to the anterior tibial artery, proximal to the aneurysm, had calcium, a lot of plaque in there, and then the proximal reference luminal diameter was about 7.2 or 7.3. All right, so with that in mind, the questions at panel, I'll tell you what we've done so far. We used we wired into both vessels, and we've got an exchange length 014 wire in the anterior tibial, and we've got a wire to be named later in the posterior tibial. And the questions for the panel is what order to do things. Would you fix the anterior tibial first? After that, would you use distal protection? Would you use any atherectomy device either in the anterior tibial or in that diffuse plaque before the aneurysm? And then if we need to put covered stents, which I think is going to be clear, would you fix the posterior tibial artery now or when we're done to maximize runoff, even though he's not ischemic in that angiosomal distribution?
So, Chris,
So I've done a lot of talking. I want to hear from the panel now.
Chris, I'm going to give a quick answer and then hand it over to the panels. This is a very great presentation and a very complex situation that we're in. The perineal artery done a great job distally, giving off the anterior and posterior communicating arteries, supplying the PT and part of the AT. And the primary problem for the AT is the ostium has a slow filling coming off from there. And I totally agree. Probably the one thing I would focus on here is just get some flow into the AT and see if you have a brisk flow to the foot. And if the pedal loop is reconstructed with that, probably would stop there and focus on the popliteal. That would be my initial take. Tony?
Yeah, I would agree. I mean, the work that you came to do was for the ulcer. So sort of focus your attention on what would it take to actually improve that, and that would probably be the AT in going through that territory. Then the other question is, how do you take care of an osteal AT with that kind of angle? I mean, the desire would be to do something that would allow balloon dilation to be successful, some form of atherectomy, but a form of atherectomy that would really hug the wire and not allow for much wire bias, so something that might have some extension on the front. In this case, I would potentially use something like a solid crown orbital device. You could use a low-profile rotablator. I mean, there's a lot of things you can use, but I think safety is kind of the major concern here. And if I saw the wire taking a strong bias towards that lateral segment, I'd probably abort that portion of the atherectomy and just go ahead and balloon that area. But the key is to get the AT opened up. I'm not as convinced as you are that the popliteal has to be fixed, and I'm telling you why. Because the runoff still is not completely established. And to treat a popliteal because of the question of whether there's been embolization from it, and it's 2.2 centimeters by your CT, I think that could be a fight for another day if you really prove that it needs to be done. And you're putting a Viabon at a territory where distal to it, the runoff is clearly compromised. So I would think twice about that as I'm definitely doing that.
Good thoughts. Now, how would with regards to that question, Tony, and I think that's an excellent point, because as you know, one of the fights is what we don't want to have is an occlusion that happens acutely later by standing across the knee joint. Completely excellent point. He's got very complex plaque and disease in the SFA proximal to that, so it's going to be very hard to treat that without treating the aneurysm, I think, although that's open for discussion.
Well, get to work and show us what you're going to do.
Okay. Any other comments before we start? And Sherry, get ready for the rotablator slide I want to show for just a second. But any other thoughts from the panel?
I'll just answer your other question. I would, if you decide to go ahead and take care of the aneurysm today, I definitely would use distal protection.
Okay. Yeah. Is that Rich?
Yep.
Chris, it's,
hey, Rich, thanks.
It's Lawrence Garcia here, but a couple things. One is I think you're right. If you start treating this popliteal aneurysm, I think you're going to chase it all the way up to your proximal third of that SFA. So it's going to be a relatively long stent. So you may want to be a little hesitant there. And to add to Tony's point about this ostium of the AT, the directional atherectomy device, the SX cutter is probably the bulkiest of the smaller vessel cutters, and it tends to stay it gets you into the cutting window in a coaxial way to the origin of that AT. It's really a good device for cutting origin disease of these types of angulated segments. So that would be one other alternative to choose.
Chris, it's Sonia. I wasn't going to say it, but I'm going to say it anyway. This is a great rota case.
Okay.
So you got all
that. So Sonia, and so we have all kind of, and we might as well mention in there that there's a small pathway device that might make it, again, these angles a little bit more concerned, at least in the anterior tibial. So I'm going to go back to slides for just a second. Can we do that? Sherry and Phil back here. Can we go back to our slides? Okay. I want to look at this. Tony and some of the coronary guys, Rich, I want to tell you, I love rotational atherectomy. This is a case I did 2 days ago, and if you notice that right's gone, there's no ability for a balloon pump and you see the calcified left main. Next slide. So that was done with rotational atherectomy and then the final result on the right. So you can come back to us, please. The reason I show that Sonia is I love rotablator. Okay, I have trained with Greg Braden and one of the rotablator guys who, God rest his soul, unfortunately expired too early for all of us. But I believe in the technology. The reason I'm choosing not to do it here with my rotational experience in the coronaries, and I may be wrong, is just the angle into that, and then with IVUS, the lack of heavy calcification. And what I don't want it to do is to jump and have wire bias and then go into that second lesion or second bend, which I think you're probably right, and in your hands, and hopefully in Mark's hands or my hands, we could do that carefully, but that's why I chose not to do that. But I think your point's excellent, and we struggled long and hard with that decision.
Yeah, Chris, Rich here. That is a type of angulation that in the coronaries would be very concerned about the catheter jumping and getting a perforation. You can't get away with it if you are very, very careful about just poking at the lesion and trying to do anything you can to keep that catheter from jumping forward. So very, very gentle pressure. Let the device take itself through rather than pushing yourself through if you would use a rotational atherectomy.
Right. I think those are fantastic points. And if we did choose to do rota, obviously we'd take the wire out of the tibio-peroneal trunk and do just that. My concern, and having wrestled with it, having the rotablator in the room, and everybody in our lab knows that if I think about rota 3 times in the coronary, they absolutely open it without asking me again. We're going to think about it 3 times in this case and not use it. So let me make a roadmap, and then I'll show you what we've chosen to do, and then we'll move forward here. So let's make a roadmap. I'll tell you when to inject, please, okay?